Okay, so let's get started from the beginning. We are going to discuss the infectious keratitis today. So, infectious keratitis, there is a common approach to approach different causes of infectious keratitis that we are going to discuss right now. It will be the history, the examination, the investigations, and the management. So, what are the concerns in the history that will be important to diagnose or to have a clue about the diagnosis of infectious keratitis? As any history of any disease, we start by onset and the course and duration. So the onset can be sometimes acute, can sometimes be insidious, but for most of cases it is acute. The course, it is mostly progressive course. The duration also will be helpful to know what is the stage of the disease. As I just mentioned to you, for some diseases like acanthamoeba keratitis, you would read in the books that it present with ring ulcer or ring infiltration. However, this is not early in the course of the disease, this is late. Also, to ask about the recurrence is for viral infection. For instance, they will characterized by episodes of recurrent episodes. So this also characteristic for viral infection. Also for some diseases like recurrent epithelial erosion. So some diseases has a tendency to recur. Trauma is a risk factor for many and many corneal conditions. One of them is infectious keratitis. It can predispose to any kind of infection like bacterial, like fungal. Personal, like the kind of job of the patient, like if the patient is a farmer, he may be at a certain risk of fungal infection, or if he is exposed to non-clean water resources, he may be at risk of acanthamoeba keratitis. Systemic diseases also can result in immune suppression, and as well as the immune suppressive states like HIV, they make the patient at risk of opportunistic infection. Contact lens use also have been associated with higher risk of infectious keratitis. Steroid use due to a state of immune suppression, and antimicrobial use also should be inquired about to know if the patient developed if the patient is receiving the wrong treatment or not. Then, after going through these clues in the history, we proceed with examination. So for examination, the first thing is to document. Like, we wanted to document the size of the ulcer, the shape of the ulcer, the location of the ulcer, whether it is involved, which layer does it involve? Is it epithelial? Is it stromal? Does it involve the whole cornea or not? This will be very important for follow-up. Then test the sensation before doing any maneuver to exclude the viral infection. It is not only the viral that will cause decreased sensation, but it will be one of the most important causes in terms of infectious keratitis. So we need to test the sensation. Also, we do fluorescein staining to check for any epithelial defect. And then we assess by this word pedal. What does this word refer to? Every letter will count for an important symptom or sign that will be suggestive of infectious keratitis. For P, it is for pain. So the more pain, the more you think of infectious keratitis, but it is not mandatory. E for epithelial defect. Again, it will be suggestive, but not confirmation for infectious causes. This is D for discharge, A for AC reaction, L for localized infiltrate. So when you check for a patient with infectious keratitis, these words will be helpful for you. First of all, to think of infectious etiology, and the second is if we are considering an infectious etiology, this will be a guide for us for treatment. Should we go for aggressive treatment, or can we just decrease the dose of treatment? This will be dependent on these symptoms and signs. After making a diagnosis of infectious keratitis, we can sometimes be confused. Which type of infectious keratitis is this? Could it be bacterial? Could it be fungal? So we opt for investigations. The gold standard for investigations in infectious keratitis is to isolate the causative organism by scraping and then doing staining, culture, and sensitivity. So we do scraping from the corneal surface, as I'm going to show you in just a few minutes. Then we do staining by different stains characteristic for bacteria and fungi. And we'd also do culture and sensitivity to know what will be the most appropriate antibiotic for these kinds of organisms. If all these are not yielding the organism, then we can opt for corneal biopsy. After that, we do the management. The management will be in the form of antibiotics specific for the organism, cycloplegics to relieve the pain, analgesics also to relieve the pain, and steroids, but the steroids is just to be given in cautious manner, like we only give steroids under cover of antibiotic in order to minimize the flare up of the infection, but can be used. So don't worry if you are using steroid, or don't be afraid to use steroids. Steroids can be very helpful for such cases to minimize the inflammation and the tissue destruction. But again, they should be used wisely. After that, there will be one of three scenarios for the infectious keratitis. The patient could be improving or deteriorating, or they could develop complications. So if they are improving, you are just to continue what you are doing, even if the result of the investigations or scraping and staining and the culture and sensitivity are revealing another organism. If the patient is improving, you just keep what you are doing. Just keep what are you giving the patient, whatever the antibiotic that you are giving the patient. If the patient is deteriorating, so you are considering different causes, like if the patient is not compliant on the treatment, or if the patient, or if it is wrong diagnosis, like if the patient has bacterial infection, but you are giving antifungal treatment, or you can consider that the patient is developing toxicity from the medications, like toxic medicamentosa. So you will find that the epithelium is irregular. There is persistent epithelial defect. So you are just stop the treatment and switch it to preservative-free artificial tears until this toxicity is improving. Or if the patient is developing complications as perforation, and this is what we are going to discuss also in just a few minutes. Okay, so this is just a mind map for you to understand or to make to develop the mindset of how to manage a patient with infectious keratitis. So let's get in depth and in more details about each case of infectious keratitis. How do they present, and how do we investigate, and how do we manage based on this general frame? Let's start first by the most common, or the first of all, the how would we do cornea scraping. So the cornea scraping is a technique that we use for taking a specimen from the cornea in order to analyze by just direct staining to detect the infective organism, or to do culture and sensitivity to know what will be the appropriate antibiotic. So after doing or opening the eye with a speculum, we can now check the ulcer. So we can find that we can now use a sharp instrument. This sharp instrument will be either a blade 15 or a hypodermic needle to take a specimen from the ulcer. So which part from the ulcer do we take the specimen? It will be the edge and the base. So we take the specimen from the edge and base, and the microbiologist will put them in the broth solution to allow the growth of the organism. And now we put them onto different plates, like chocolate agar, like blood agar, like that, in order to facilitate the growth of the organism. So blood agar is used for aerobes and fungi. Chocolate agar is used for Haemophilus and Neisseria gonorrhea and Moraxella. Different kinds of agars used for different kinds of organisms, like McConkey for gram-negative rods. And Sabaru agar for fungi. Also, we can use the specimen for gram staining. So we spread the specimen on a slide After fixing it, we can examine it on the by hematoxylin and the eosine for different kinds of gram positive and the gram negative, and for other kinds of staining for the different organisms. So we can use this by what's called Kimura spatula, or we can use the plate 15 or hypodermic needle, taking a specimen from the edge or the base of the ulcer. So this is just for the technique. If you are asked in the exam, you will be asked about what is the location of the ulcer, or what is the location that you should take the specimen from, and also you will be asked about what kind of plates or agars that you are specific for different organisms. Okay, so let's start first by the bacterial keratitis. We are now going to discuss the infectious keratitis by the cause of organism. So starting first by the bacteria, there are certain risk factors for developing bacterial keratitis. We already summarized them, but let's focus on them more. It will be the contact lens, trauma, foreign body, ocular surface disease, like severe dryness, as we are going to discuss right now. It will cause lost epithelium, which will be the first barrier that will protect the cornea against infection. Topical steroids causing decreasing the immunity, and immunocompromised patient will be also more liable to develop any kinds of infection, even with low virulent organisms. So these risk factors usually disturb the normal or natural defense mechanism of the cornea. Like the cornea is protected by a tough layer of epithelium, which act as a barrier that will prevent a passage of organisms into the cornea. But so if the contact lens is present, it can disturb the epithelium. If trauma, it will also cause loss of the epithelium as well as the foreign body. However, there are some certain bacteria that even can invade the intact epithelium. These bacteria are called the Neisseria, the Clostridium diphtheria, the Listeria, and the Haemophilus aegypticus. So these organisms are capable of invading the intact epithelium, so please don't forget them. So how do the patients with bacterial keratitis will appear? Well, the universal clinical manifestations are the presence of epithelial loss, which will present by epithelial defect, appears with the fluorescein staining, and there will be stromal infiltration. So this like yellowish or grayish or whitish material, like these deposits present in the stroma causing thickening of the stroma. It is called stromal infiltration. Also, they may be present with hypopyon, like that, in the anterior chamber, and present with conjunctival injection. So these are the most common manifestations of bacterial keratitis. So the spectrum of different organisms will be very very common with each other. Like you may find some books saying that it will be some organisms causing whitish, some organisms causing yellowish. Will be, it is not always like that, because as a matter of fact, mixed infection is the rule for these cases. So it will be more likely to be a diagnosis by laboratory, by doing scraping, staining, and culture, rather than a clinical diagnosis to know what is the specific organism. So how would we investigate for those patients? As we mentioned, we do cornea scraping for gram stain, Giemsa stain, calcoflower stain for fungi to exclude fungus. So this will be the routine. This will be the routine for any case of infectious keratitis. We do the gram stain, Giemsa stain, calcoflower to exclude bacterial and fungal infection. Culture and sensitivity on blood agar, chocolate agar, Saburo agar. Again, this is the routine for bacterial and fungal infection to exclude which one will be the cause. Corneal biopsy, if the previous methods are not working or not yielding any organism and the patient is deteriorating, we can opt for corneal biopsy, especially if there is sight-threatening or severe infection or large infiltration with tending to involve the whole stroma, chronic patients, unresponsive patients, or if there is any feature suggestive of a typical organism. So what will be the treatment for bacterial keratitis? It will depend mainly on the word pedal. Remember pedal, the pain the epithelial defect, the stromal infiltration, the reaction, the discharge, the location, if it is central or peripheral. So if the manifestations are severe and the patient has like large stromal infiltration with large epithelial defect and massive reaction with the hypopyon, those patients are unlikely to be respond on single drug. So we opt for fortified antibiotics or dual therapy. If the patient has minimal manifestations, like very small infiltration, like 1 maximum 2 millimeters, it is peripheral, it is not central, not affecting the vision, there is minimal or no reaction. So we can start by single therapy or monotherapy, such as fluoroquinolones. So the choice of the drug depends mainly on the clinical presentation. So for mild cases, we start by fluoroquinolones like hourly for the first 2 days, and then we decrease the dose depending on the response. But for severe cases, we start by the fortified antibiotics. The fortified antibiotics, we need to cover the gram positive and the gram negative. So there are certain antibiotics with their main spectrum on the gram positive, and other antibiotics with main spectrum on the gram negative. So like, for example, we can use the vancomycin for the gram positive and the ceftazidime for gram negative, 50 milligram per milliliter. It will be by diluting these antibiotics on artificial tears or BSS. So those patients can receive these topical antibiotics again hourly for the first 2 days. Then we grade them or we cater or we tailor the response or tailor the dose of the drug depending on the response of the patient. So whether we are continuing the same drug, if there is improvement, we are decreasing. If there is great improvement, we can just decrease it to every 2 hours or every 4 hours or every 6 hours. And if there is no response at all, we may consider, as we said, the failure of treatment. So we may consider to change to another drug. Okay, so this will be like a brief about the bacterial keratitis. So today we are going to discuss many topics about keratitis. So I hope that you just don't get lost with me. Please be focused, so that you don't confuse between different kinds of keratitis. Okay, so this is not only the treatment, but we can also give cycloplegics to relieve the pain, steroids if the patient show improvement of epithelial defect, if there is improvement of the clinical manifestations with the ulcer become well defined, as I'm going to tell you what are the signs of healing. So in this case, we can add a steroid. And cycloplegics also are important for all cases of keratitis to relieve the pain of the patient. The next thing or the next topic is the fungal keratitis. So fungal keratitis, it will not be an exception from risk factors of infectious keratitis. So it will be the same risk factors like contact lens, trauma, foreign body, ocular surface disease, topical steroids, immunocompromised patients. However, there are certain risk factors for certain etiologies. Like in the fungal, we can think of the risk factors as suggestive causes for which type of fungus is the causing the problem. For example, the contact lens, the trauma, the foreign body are more suggestive of filamentous fungi. Like it can be due to aspergillosis or fusarium. So the trauma with vegetable matter, the contact lens, the foreign body are more common to be causing the filamentous fungi like aspergillosis and fusarium. On the other hand, patients who have poor ocular surface or poor immunity, either by topical steroids or they are having systemic immune suppression, they are more likely to be having non-filamentous fungi or the candida. So these risk factors can enlighten you about what is the causative organism specifically. The fungal infection can have some specific features to the fungus, like the presence of satellite lesion. So the lesion tend to be multifocal, as you can see here. This multifocality or the satellite, the main lesion is here with 1, 2, 3, 4 multifocal lesions. So these satellite lesions are suggestive of fungal infection. Also, the presence of feathery edges This can be suggestive of fungal infection. The presence of endothelial plaque, the presence of hypopyon like that. These also some characteristic of epithelial infection. The fungus tended to invade and penetrate the descemet membrane. So it tended to be more posterior. So when you have a patient with posterior stromal infiltration, think more about the fungal infection. So it tended to involve the descemet, tended to involve the endothelium, and also causing this hypopyon. So if we are suspecting fungal keratitis, what should we do? Investigations, again, like gram scraping for gram stain, Giemsa stain, calcoflower stain, culture and sensitivity on blood agar, chocolate agar, and Sabaru agar, and the corneal biopsy. If we are having or we are suspecting that the patient is fungus or fungal infection, this will be based on the history, the clinical presentation, so we can start the antifungal treatment from the beginning. What will be the antifungal treatment? Well, it will be depending on the cause. So if it is filamentous, like Aspergillus or Fusarium, the treatment of choice or the drug of choice will be the natamycin eye drops, the topical natamycin. If the patient has a non-filamentous infection like candidal infection, the antifungal of choice will be the amphotericin B, and together with systemic antifungals such as voriconazole, itraconazole, fluconazole, miconazole. These can be systemic antifungals that can be supplementing the topical antifungals to fight the infection. Okay, so this will be the details about the fungal keratitis. Okay, for the next is also another entity of fungal keratitis. It is the microsporidial fungal keratitis. Microsporidial fungal keratitis has its specific features. So first of all, what is the microsporidia? It is an obligate intracellular parasite. It was thought previously that it is one of the helminthes, but it is now considered more of a parasite. So it is a disease that is rare in normal healthy individuals. It is more common to be present in patients who are immune suppressed. So it is more common in the HIV patients. And usually those patients have a state of immune suppression. So this drug is associated, or this fungal keratitis is associated with underlying systemic problem, which is enteritis. So if it's asked you in the exam, what will be the commonest systemic association or systemic problem will be enteritis. Enteritis, the problems within the intestines. And the commonest infection or the commonest ocular infection is keratoconjunctivitis. So those patients have keratoconjunctivitis. So what will be the presentation of those patients with microsporidial fungal keratitis? They first start with punctate epithelial keratitis. Then these punctate epithelial keratitis will show unilateral, slowly progressive deep stromal keratitis. Remember the word deep? Remember that the fungal usually is a deep infection. So this is for the classic presentation. Actually, for the patients who are healthy, it will cause stromal keratitis, but for immunocompromised, it will tend to cause keratoconjunctivitis and epithelial keratitis. Also, other manifestations that can occur like anterior mediastromal infiltration, anterior uveitis, or even gross corneal necrosis and perforation, especially in patients who are immune suppression. So you can see this is how does a scar or stromal infiltration looks like. It will be very difficult to diagnose this patient without any kinds of investigations. But in the early stages, like when it is multifocal, present with multiple stromal infiltrates, this multiple focal stromal infiltrates, it will be more easy to diagnose. Dr. Khadija, do you want to ask anything? Let me unmute you.
Sir, hello, sir. Hello.
Hello, yeah.
Yeah, sir, I just wanted to ask, why does microsporidia cause stromal keratitis in healthy individuals, and why does it infect the superficial layers in immunocompromised people, sir?
Well, maybe there is no actual explanation for that. This is what was just mentioned, but there is actually I don't have a certain explanation for this. But let me try to look
Okay.
for a reason for that, and I will get back to you.
Okay, okay, sir. Thank you.
You're welcome. Okay, so again, we are continuing with the microsporidial keratitis. What will be the different presentations? So we said that it will causing the stromal keratitis or epithelial keratitis, and can cause other manifestations like anterior uveitis or corneal necrosis or perforation, especially in the immunosuppressed. Okay, so how would we investigate? If you see a patient like that, it will be very difficult for you to diagnose it. So you need some sort of investigations to confirm your suspicion. Actually, the gold standard for investigation or gold standard investigations for patients with microsporidial keratitis is the transmission electron microscopy. This transmission electron microscopy will show the fungus or the microsporidial fungus. However, this kind of investigations is expensive. It is not very widely adopted or present. So it is not available everywhere. Other investigations that can be used is the simple light microscopy using stains. Calcoflower white and this orange trichrome stain can be also useful to delineate the fungus and stain the fungus. Other methods of investigations are the immunofluorescence assay and the PCR. So how would we treat those patients? The treatment will be for immunocompetent. It will be self-limited. So usually no need to treat those patients for having the microsporidial keratitis. So it is the immunocompetent, the usually it is self-limited. And for immunocompromised, it will be dependent on what will be the level of infection, whether it is epithelial or it is stromal. So for epithelial disease, they will take an antifungal drug. It's called the fumagillin. The fumagillin will be used for epithelial disease. And for the stromal disease, they will be needing also the topical fumagillin, but together with systemic therapy such as oral albendazole, active. Just hold on for a second, please. The highly active antiretroviral therapy. For complications like perforation, they will be should be receiving the keratoplasty. Okay, just hold on for a second, please. Sorry, I'm having some problems with the connection. I will just correct them and I'll get back to you. Hold on, please. Hello, sorry for the this lag. I just had a problem with the connection. Let me share you my screen again. So doctor here is Dr. Hager is asking, is microsporidia is very painful? Well, no, the microsporidia will cause like some sort of photophobia and redness, some discomfort, as it will cause some conjunctivitis as well, but not that severe pain. Actually, the fungus, there is like a famous word for the fungus. It's called that the fungus causing white and quiet eye. So not every case is very painful, but this is doesn't have to be the rule. Like if you have a patient with severe stromal infiltration, but it is not correlated with the clinical presentation, this is when you suspect the fungus infection. But this doesn't mean that every fungal infection is not painful. Okay. So let me share you my screen again. Okay, clear about the fungal infection and the sorry for because I'm just using another laptop, and in this laptop it doesn't it show you or show me your chat box. There is like the zoom here is not that good. So excuse me if just I have some delay in responding to your questions. Okay, let's now move to the next topic, which is the acanthamoeba keratitis. The acanthamoeba keratitis is one also of the famous infection, or it is not that common in practice, but it is famous in the exams. So they tend to ask about them in the exams. So let's see what is the acanthamoeba. Acanthamoeba is a kind of parasite that is actually it is a normal commensal. It is present in the skin, in different body organs. However, they become invasive and under certain conditions. First of all, if the patient is wearing contact lens and he has poor contact lens hygiene, like if he is swimming with the contact lens, bathing with the contact lens, using a tap towel or tap water in order to wash the contact lens, not its own solution. So this will be a risk factor for developing the acanthamoeba keratitis. So remember that the acanthamoeba keratitis can be present in the stagnant water, unclean water. So these can contaminate the contact lens, and when the patient is putting the contact lens on the eye, they will tend to invade the eye. Remember when I told you that the contact lens is one of the risk factors for developing infectious keratitis. So the contact lens have been specifically linked to two kinds of organisms. It can be present with any kinds of infection, but when the patient is present with contact lens related infection, always think about the acanthamoeba keratitis and the Pseudomonas keratitis. And by terms of frequency, the Pseudomonas is more common than the acanthamoeba keratitis. Okay, so you need to inquire about the history of contact lenses specifically. And if the patient even is denying any history of contact lens use, don't neglect the acanthamoeba keratitis. It also can be present. So if the patient is exposed to contaminated water resources, they will also can develop acanthamoeba keratitis. So what is the clinical presentation of acanthamoeba keratitis? Again, focus because this is one of the hot topics in the exams, very frequently asked. The history or the clinical pathway or the clinical presentation of the acanthamoeba keratitis depends on what will be the level or what will be the what stage did you catch the patient on. Usually those patients are misdiagnosed and usually they present late. So first of all, those patients present with severe pain. The pain is more than signs. So you see the patient, you will find that there is no signs, there is minimal infiltration, there is minimal epithelial breakdown, but you see that the patient is very in agony. The patient is in very severe pain. So you just wonder, why does this happen? Remember the acanthamoeba, it will cause this. Then as the organism, as the acanthamoeba trying to infiltrate the epithelium and subepithelium. So they will cause grayish whitish epithelial and subepithelial infiltrates. At this level, this can be sometimes confusing with a patient with viral keratitis. They will cause pseudodendrites. Pseudodendrites similar to that of the herpetic keratitis. So at that level, when the organism is invading the epithelium and stroma, it can cause the appearance of pseudodendrites. Then they will reach the stroma. So at that level, they will present with patchy anterior stromal infiltration with epithelial breakdown. So it will be misdiagnosed as herpes simplex. Then it will cause perineural infiltration. Remember when I told you that there is a severe pain? Why this severe pain? Because this organism has predilection to involve the pericorneal nerves. And the corneal nerves, it will cause perineuritis or perineural infiltration. So this will result in severe pain. And as the organism is reaching the stroma, it will cause ring infiltration because of its tendency for circumferential spread. Also, the problem with this acanthamoeba, not only that the disease is difficult to treat, and it takes long duration for treatment, but also it will show high tendency to recur after penetrating keratoplasty. Like if there is remnant cysts, deep cysts are embedded within the stroma, and you just remove the graft, remove the cornea, put another graft, but there is still some cysts in the recipient, or so they will tend to recur in the graft, like about 30% incidence of recurrence. So let's see what are these presentations in illustrated form. So you see in the area or in that level, you see this patient present with very few signs. You can see that just there is some irregularity in the epithelium with grayish white epithelium irregularity, and it looks like a dendrite. It looks like it has a dendritic pattern, but you may suspect that this is a case of epithelial keratitis. But at that level, the patient is complaining of severe pain. As the organism is spreading, they will involve the stroma, causing this stromal grayish or multiple stromal infiltration with this grayish or whitish pattern. The organism also tended to involve the corneal nerve. You can see how much the corneal nerve is inflamed, causing what's called a neurokeratitis or perineural infiltration or perineuritis. All these terms refer to the same thing. It is the infiltration of the cornea or infiltration of the corneal nerves. You can see the epithelial breakdown. There is multiple stromal opacities represent the stromal infiltration, and there is starting is the ring infiltration. So at this level also there is a severe infection and severe pain. Also, this is a kind of ring infiltration, which will be highly suggestive of acanthamoeba. So ring infiltration is not the initial presentation of the patients with acanthamoeba keratitis, but they occur as the disease is progressing. So how can we diagnose a patient with acanthamoeba keratitis? There are many ways to diagnose the acanthamoeba keratitis. So it will be just you have to have high index of suspicion and then to order the appropriate investigations. Different kinds are hematoxylin and eosin. They can show the cyst of acanthamoeba, as you can see here. Another stain, which is the periodic acid chaff, can also be useful for diagnosis, as it can show the cyst of acanthamoeba keratitis. The Giemsa stain also can be used for acanthamoeba keratitis. Calcoflower white stain, it can be also used as it can be, like the acanthamoeba will having common features from the fungi and the helminthes. The culture will be on non-nutrient agar seeded with E. coli. So this is a normal non-nutrient agar, but we put the E. coli on this non-nutrient agar in order to facilitate the growth of the acanthamoeba keratitis or the acanthamoeba organism. This is also very commonly asked in the MCQ exams. Remember, the culture is on non-nutrient agar seeded with E. coli. The gold standard for diagnosis of acanthamoeba keratitis is the confocal microscopy. So there will be like live visualization of the organism itself within the corneal tissue. And another final way for diagnosis will be the acanthamoeba by the PCR. So doing PCR of the corneal tissue will cause augmentation and amplification of the DNA of the organism, so we can use it for detection of the organism. So these are the different methods for diagnosis of acanthamoeba keratitis. I hope that this is useful. So how would we treat a patient with acanthamoeba keratitis? Treatment, as I told you, is difficult. It takes a long time. The response doesn't have to, or doesn't is usually not very favorable, especially if the patient is presenting late in the course of the disease, as the organism tends to invade deep in the stroma. So the penetration of these drugs may be not very good, so doesn't reach or don't reach the organism. So we do like combination treatment of antifungal, antibiotic, and antihelminthes or antihelminthic treatment. So we use what's called the biguanides. Biguanides, we can use one of these drugs, the polyhexamethylene biguanide or PHMB, or chlorhexidine. We use one of them, whatever available, polyhexamethylene biguanide or chlorhexidine. Then we use together with another drug, which is called the diamidine. The diamidine, either the probamidine isocyanate or the proline, or the hexamidine. So we can use the proline or the hexamidine. Then we should add aminoglycosides such as neomycin or paromomycin, and systemic antifungals from the azoles like ketoconazole, itraconazole, fluconazole, clotrimazole. So this will be like the standard treatment for acanthamoeba keratitis. And there are other methods like maybe there is no response, so we can opt for something like cross-linking. If there is like a severe infiltration that is not responsive for treatment, we can opt for therapeutic keratoplasty. If there is perforation, we can go for tectonic keratoplasty. Other methods, but I'm just talking now about the systemic antibiotic therapy or systemic and topical antibiotic therapy or the anti-acanthamoeba therapy. So these are the lines of management for this kind of infection. Okay, so I hope that this is clear. So this will be the like the infectious, like the acanthamoeba, the bacterial, and the fungal. So you may have a question: how should I know that the ulcer is healing? How should I know that the patient is improving? And I need to switch my medication to another drug, or should I keep using the same drug? There are certain signs of healing ulcer, and there are signs of a complicated ulcer. So for healing ulcer, there should be decreasing pain and congestion. There will be consolidation and sharp demarcation of the edge of infiltration. This is one of the most important signs. Like this is one of my patients. You can see that he has a minimal infiltration, like around 1 millimeter or 1 to 2 millimeters, not very central. It is peripheral, and there is no anterior chamber reaction. From practice, I know that this is the kind of staph infection. This is how does the staph keratitis present. So I just give him a moxifloxacillin like every 2 hours for 3 days. And this is how does the patient present after 3 days. You can see how much is the consolidation and the sharper demarcation of the edge of infiltration. You can see here that the infiltration is active. It is elevated, it is yellowish, and the margins are ill-defined. But with improvement of the condition, with the response, you can see that there is consolidation and there is well-defined margins of the ulcer. Okay. Also, and for the next follow-up visit after 3 days, another 3 days, there you can see that the scar tissue, the residual scar tissue is trying to break down. There is breakdown of the scar tissue, so it will tend to after the collagen remodeling, which takes months to happen, there will be a regulation of the collagen fibers and decrease the density of the scar tissue, causing much improvement in the condition. Okay, so apart from the consolidation and sharper demarcation of the infiltration, there will be decreased stromal edema, a decreased endothelial plaque and hypopyon, and decreased anterior chamber reaction. So again, remember the pedal mnemonic, it will be showing decreasing the signs and symptoms of pedal. But what will be the scenario if the complications happens? Like if there is perforation. First of all, how would we know that there is perforation? We know what by a test called the Seidel test. Seidel test, in which we are putting a fluorescein strip over the ulcer and check for the gush of aqueous from this perforation. This is again one of my patients. So this patient, you can see, has a central perforation. And I'm putting here the fluorescein stain. And you can see the flow of aqueous from this perforation. This is what's called the Green River sign. So how should we manage a patient? If the patient has a perforated ulcer, how would we manage? Well, the management will be dependent mainly on the size and site of the ulcer. So for this patient who has minimal, very small ulcer, very minute ulcer, and the patient received topical and systemic topical antibiotics and just bandage contact lens and the ulcer healed or the perforation healed. So if for only 1 week, I don't know if my resident, Dr. Muhammad, is present here. He would know that better. Dr. Muhammad Rida, you remember this patient? Okay, so this patient was so Dr. Muhammad was with me with this case. So remember this patient, we were arguing whether we should admit in the OR for gluing to do a cornea glue or not, and eventually this patient only improved on the bandage contact lens, just contact lens, and after 1 week the ulcer or the perforation sealed itself. So he had lost anterior chamber, shallow anterior chamber, and soft intraocular pressure. With just contact lens, he is improving. So here is the look, the size of the ulcer has the upper hand. So what are other medications that we should give the patient? Anticollagenase, like tetracycline. We don't give tetracycline for its antibiotic effect, but for its anticollagenase effect. It will decrease the melting of the tissues. So especially if there is underlying inflammatory process. Aqueous suppressants, bandage contact lens, adjuvant treatment like vitamin C to help promotion of the epithelial healing and stromal healing, vitamin A and vitamin C, systemic immunosuppressive for systemic disease to control the underlying condition. But for surgical conditions, or if there is perforated ulcer, then we have other surgical options. Especially if the ulcer is large or if the ulcer is more central. So for small peripheral ulcer, we can observe the patient, like sometimes the iris will plug the ulcer, so or plug the perforation. So we don't need to interfere for every case. But for more the larger and the central ulcer, there will be other surgical options. For example, if the ulcer is small, we have tissue adhesives like cyanoacrylate and fibrin glue, with different indications of both of them. For moderate ulcers, we have the conjunctival flap and the amniotic membrane graft. And for other options where the ulcers is very large and will not be responsive for these kinds of treatment, there will be the tectonic graft and the scleral patch graft. So let's check for the first one, which will be the tissue adhesive. Here is the tissue adhesive. You can see that there is a small ulcer here or small perforation here. And then we did a tissue adhesive. This can be what's called cyanoacrylate. So the cyanoacrylate can be used mainly for the central, which are away from the limbus. This will be the best for to be done by the cyanoacrylate glue, and also it will be best for the corneal infection which are due to infectious origin, because in the fibrin glue, on the other hand, it will be better for peripheral and it will be better for the non-infectious etiologies. Why is that? I will tell you why. Because actually the fibrin glue has a tendency to crystallines. You can see it will make like crystals or make like this crystalline pattern, and this, if it is present in the periphery, it will tend to slough off. So it will tend to slough off, and also since that it is an artificial substance, the organism tend to, it is a bacteriostatic, so that the organism will not grow over it. So the cyanoacrylate has this advantage of being bacteriostatic and last longer than the fibrin glue. However, the fibrin glue is better for the peripheral ulcer because it will be fit more on the limbus or in the limbal area, and also it will be better for the non-infectious etiologies. Okay, so this will be for the tissue glue. The tissue glue is usually reserved for small ulcers, like it will be like less than 2 millimeters, or it will be like 1 millimeter ulcers. This will be the treatment of choice to seal this ulcer will be the tissue glue or the tissue adhesives. Other methods are conjunctiva flap. Conjunctiva flap is a way to close the cornea or the defect in the cornea by just the by a flap coming from the conjunctiva. So let's see, I'm again showing you one of my patients. This is a patient who had like a corneal perforation. This is actually the sloughed cornea. This is the cornea which is totally sloughed after bacterial infection, showing an iris prolapse. So this patient was, I did him a conjunctiva flap. You can see this is the conjunctiva flap, and this is again from a side view of the conjunctiva flap, trying to closing the defect as much as possible. At that time, actually the conjunctiva flap should be done for defects which are not very large, because as you can see here, this patient has a very large defect. So after forming of the anterior chamber, the iris prolapsed again and the conjunctiva flap is under tension. So this will be a downside for the conjunctiva flap. So we can just reserve them for defects which are between like around 3 to 4 millimeters. For larger defect, and another way to do a closure of this defect, if there is no enough conjunctiva, be by amniotic membrane graft. So amniotic membrane graft can also be used for cases which there is perforation more than the limitations of the amniotic of the glue, and we want a less invasive procedure than the keratoplasty. So defects between 1 to 3 millimeters also can be managed by amniotic membrane graft. For the next one is the tectonic graft. So if the patient has a perforation and this perforation is not improving, or it is beyond the limitation of the graft, beyond the limitations of the glue and the conjunctiva flap and the amniotic membrane graft, we can do tectonic graft. So a tectonic graft is used to restore the ocular integrity. Like if there is perforation, like in this patient, this is also one of my patients. This is there will be like central perforation, and there is also stromal infiltration. So what we do a graft not for vision. It is not for vision. It is just to restore the ocular integrity. So what happens? That I did here a tectonic graft. So I took a graft from a patient who had like trachomatous corneal scar, and put it here because this was an emergency to seal this large perforation, and so this was just done to restore the ocular surface to prevent the persistent opening of the anterior chamber with higher incidence of endophthalmitis. So this is called a tectonic graft, where we are doing a corneal graft to restore the ocular integrity. Another way is just to do a penetrating keratoplasty. Like if the patient has, this is also one of my patients. This patient has severe corneal infiltration and opening, central opening, and the perforation. So I did him like a penetrating keratoplasty. This is the second day post-operative. So to just to remove the infection and to remove the perforation. So I'm here doing this graft for vision. Like I'm putting him a clear graft in order to restore the vision. So this is a different kinds of maneuvering or management of perforated ulcer. So everyone has its indications, has its also complications, has its advantages and disadvantages, and has its limitations. Okay, so I hope that this is clear. Any questions so far? Okay, let's now talk about the viral infection. The viral infection can be classified into mainly the herpes simplex virus and the herpes zoster virus. So remember when we talked about the pediatric cornea, we said that when the first contact of the herpes to the baby, um, it can cause blepharitis, conjunctivitis, and keratitis, or what we term blepharoconjunctivitis. So the primary herpes simplex infection present usually in the first 6 or 7 years of age, present with blepharitis. You can see the hyperemic eyelid, present also with conjunctivitis, with follicular conjunctivitis. We said it is one of the differential diagnoses of follicular conjunctivitis. There will be the characteristic herpetic vesicles, the lead vesicles. There will be it is usually unilateral, and sometimes the cornea can be involved. That's why when we treat those patients, we treat the skin condition and also the corneal condition. So we give antiviral skin ointment, antiviral eye ointment. Systemic antiviral also can be given, and antibiotic skin ointment by the dermatologist in order to prevent secondary infection of these lead vesicles. After that, the virus or the herpes simplex become dormant in the body and become reactivated later on the periods of stress or decreased immunity. So when the recurrent herpes simplex is recurring, it will present with a specific features. Like it will differ whether it is epithelial or stromal viral keratitis. What happens if there is reactivation of the herpes virus in the epithelium? This will result in epithelial lesions. These epithelial lesions can start with focal epitheliitis or focal epitheliopathy caused by inflammation of the epithelial cells by the virus. Then, with desquamation of the lost epithelium or the epithelium, this diseased epithelium will be lost. So it will result in the characteristic dendritic lesion. This is the dendritic ulcer. The dendritic ulcer takes like the dendritic pattern. And if the patient is not treated or he is receiving steroids by mistake, then this dendritic ulcer will be converted to geographical ulcer. This is a geographical ulcer. So this will be the sequence of epithelial keratitis, starting by focal epitheliitis or focal epitheliopathy, then dendritic ulcer, then geographical ulcer. So again, don't just think that all patients will be present with the typical dendritic pattern or typical geographical ulcer. You can catch them early like that. So how would you catch them? It will be by history of recurrence and also by the presence of multiple attacks. How would you know that there is multiple attacks? By examination of the levels. So you know that this patient has also hello, do you hear my voice clear? Hello. Okay, so again, I'm talking about the viral infection. How would you suspect a patient with epithelial keratitis? As I'm telling you that if you have a patient with dendritic ulcer or geographical ulcers, then you will have no problem. It is crystal clear. But you have a patient like that, it will be sometimes difficult for you if you are not like a cornea specialist. It will be difficult for you to diagnose that this is a herpes infection. So how would you have high index of suspicion with herpes? First of all, by decreasing the corneal sensitivity. The second of all, by the history of recurrence. The third of all, even if the patient doesn't remember that he had a history of recurrent attacks, you would say, or you would see this. And what is this? This is not an active lesion. This is a scar, multiple scars of previous attacks. Every attack will leave a scar. These scars are usually not very dense. They are faint or superficial. They are faint. They can take multiple levels. They can be superficial, subepithelial, can be anterostromal. So this presence of multiple stromal or multiple scars and with different in density, difference in location, will give you high index of suspicion about the presence of viral infection. So remember the recurrence and decreased sensation. Also, the viral ulcer or the herpetic ulcer has a tendency to have what's called double stain. Double stain is that when the ulcer is taking the two stains, one is the rose bengal stain, and the other is the fluorescein stain. So the rose bengal appears as pinkish, and it is staining the diseased epithelium, while the fluorescein stain will be staining the lost epithelium. So it will be the double stain that the fluorescein will be in the center, while the rose bengal will be at the advancing edge, which has the diseased epithelium. So it will stain the periphery or stain the edge of the ulcer. So when you see this pattern of double stain, this is also diagnostic or very suggestive of patient with herpes simplex virus infection. So it is a clinical diagnosis mainly, but if you are in doubt, you can order investigations. So what are the investigations? You can check like there is impression cytology and viral culture. This viral culture will, if you take a specimen and do culture for this virus, you don't do it like on classic agars, but they have a specific way for culturing. You will say intranuclear viral inclusion bodies and the multinucleated giant cells. They can also be seen by the GEMS stain. So this is if in doubt, but usually this is a clinical diagnosis. Treatment can be started by several ways. First of all, the debridement, especially if the patient has like the epithelium is horled or the epithelium is rolled in, there is persistent epithelial defect for so long. So there's sometimes if you do debridement, you are just removing the edge of the epithelium, you are decreasing the viral load, allowing the epithelium to heal. Topical therapy can be in the form of topical antivirals such as acyclovir, ganciclovir, or trifluridine. So trifluridine is more common in the US. Systemic therapy such as acyclovir, valacyclovir, and famciclovir. So we start these topical therapy by acyclovir. It started by 5 times per day, usually for 5 to 7 days. Then there will be, if there is improvement, you will continue for other 3 or 4 days. If there is no improvement, you may add systemic therapy. If there is no improvement on the topical and systemic, you will consider doing debridement. Okay, so this will be for the herpes simplex virus. This is for the epithelial, if the infection is affecting the epithelium. What about the stromal? If there is there infection or is there any infection affecting the stromal herpes virus or stromal keratitis? Yes, there is 2 kinds of involvement of stroma in patients with herpetic keratitis. It can be stromal non-necrotizing keratitis or stromal necrotizing keratitis. So how do every one of them look like? And what is the etiology of the stromal non-necrotizing keratitis, and what is the etiology of stromal necrotizing keratitis? For the stromal non-necrotizing keratitis, It will be it was a hypersensitivity reaction to the herpes simplex virus antigen in the cornea. Like if the patient has a primary herpes infection, and then there is reactivation of this virus. Actually, there is the recurrent, the stromal non-necrotizing keratitis. It is just a hypersensitivity reaction to the viral antigen. It is not an actual infection. This is very important for the management. This is not an actual infection. This is a hypersensitivity reaction. So remember when that it is a hypersensitivity reaction, so it should be treated by steroids. Steroids will counteract the hypersensitivity. So there is hypersensitivity reaction, and this hypersensitivity reaction will manifest itself as epithelial edema and stromal edema. So you will find that there is epithelial edema, a disc-shaped epithelial edema. That's why it is sometimes referred to as DC-form keratitis, because there is a disc-shaped epithelial edema overlying a disc-shaped stromal edema. So there is epithelial edema overlying stromal edema. And what about the desmus? The desmus membrane will show folds. What about the endothelium? The endothelium will show keratic precipitates, because for many occasions, those patients also can present with keratouveitis. There will be an element of herpetic uveitis as well. And this uveitis will cause anterior chamber reaction and high intraocular pressure because of this uveitis. There can sometimes be a ring of reaction between the antigen and the antibody, and this ring is called Weasley ring. Weasley ring, I think that I didn't bring an image for that. Okay, so Weasley ring is an image, or sorry, it is a reaction between the antigen and the antibody. It will appear as a ring, which will be very suggestive of DC-form keratitis or stromal non-necrotizing keratitis. So what will be the treatment for those patients? Again, you need to address the pathology. The pathology is hypersensitivity reaction, so the treatment should address that. The hypersensitivity is topical steroids. But this is a virus, this is a viral infection, or this is a response to a viral antigen in the cornea. I may give steroids leading to flaring up of the virus, causing an active infection. So we need to give the steroids under the cover of topical antivirals. So like if we are giving the topical steroids like 5 or 6 times per day, we also give the topical antivirals 5 times per day. And as we decrease the steroids, if there is good response, as we decrease the steroids, we can decrease the topical antiviral. If the patient has high intraocular pressure, they receive anti-glucomatous medications. They can also receive antibiotics to guard against secondary bacterial infection. So this will be, and also they will receive a systemic antiviral if they have uveitis. For the stromal, we give both topical and systemic antiviral. And this is what I'm just mentioning. So we give both topical and systemic because many of those patients have an element of uveitis. So for uveitis, the systemic medications will pass the blood aqueous barrier, reaching a higher concentration in the aqueous to fight the uveitis or the herpetic uveitis. And we will come to this in the section of studies. Okay, so this is everything about the stromal non-necrotizing keratitis or the DC-form keratitis. The other variant is the necrotizing type. This is a more severe form of recurrent herpes simplex. It is called the stromal necrotizing keratitis. It is actually a viral infiltration and inflammation of the corneal stroma. So it is not a reactivation, sorry, it is not a hypersensitivity reaction. It is actual invasion, like there is primary invasion of the stroma. There is the herpes is invading the stroma, it is attacking the stroma. And this is unfortunately very frequently mistaken as bacterial keratitis. I saw many patients with this picture misdiagnosed as a bacterial keratitis, and actually it is very simple to differentiate, as I'm going to tell you right now. So how do these patients will present? They will present with necrotic, cheesy stromal infiltration. Maybe this is why it is mistaken as fungal or bacterial, that they have a stromal infiltration. So many don't imagine that the virus can cause infiltration. They have only that this classic picture of the dendritic ulcer or geographical ulcer, thinking about only the epithelial keratitis, but remember that it also can affect the stroma. So last time I saw a case like that was like last week. I have a patient who was maltreated as a bacterial keratitis for like more than a month, and he's not improving, and he's in severe pain. So how did I got the idea that it is an herpes infection? First of all, he has a stromal infiltration like that, but he had this pattern of vessels. You see this pattern of blood vessels, sometimes it's called the niche vascularization. This pattern is characteristic for viral infection. It tended to like become more gathered and more condensed at the area of stromal infiltration. So this is, remember this pattern of vascularization. So this is one thing. The other thing, you see this, what is this? This is a stromal scar. Let me just point to it. I hope that you can see it. This is a stromal scar. So this means that the patient has previous attacks, which is more common with the virus. Also, for other clues, like you can find the KPs denoting viral keratitis, you can find anterior uveitis, hypopyon, and high intraocular pressure also goes with uveitis. It's like uveitic glaucoma. And you can find some clues about iris atrophy, spiral atrophy, or sectorial atrophy goes more with the viral uveitis. So this will be characteristic for viral uveitis. It is a stromal necrotizing keratitis. Okay, for those patients, they should receive topical and systemic antiviral. And by receiving topical and systemic antiviral, they will do very well. Okay. So this is the spectrum of herpes simplex uveitis. Let's now discuss about the herpes zoster uveitis, or the herpes zoster keratitis. The herpes simplex, let me tell you something about the herpes simplex. As I told you the last time, that the herpes simplex is caused by the herpes simplex virus type 1. Herpes simplex virus type 1 is causing the infections above the waist. What is the etiology of herpes zoster ophthalmicus? It is the varicella zoster virus. So the varicella zoster virus is causing a primary infection, and this infection is called chickenpox. It is a non-ophthalmic condition. Chickenpox is a skin infection with vesicles that appears usually in childhood, but not necessarily. And then the varicella zoster virus become dormant in the ganglia. And when there is reactivation by immune suppression or by stress, then they will can cause herpes zoster ophthalmicus. So the etiology is reactivation of varicella zoster virus. How do they present? First of all, they will present with punctated epithelial keratitis. It's sometimes referred to as pseudodendrite. So it starts by punctated epithelial keratitis, then progress to pseudodendrite. It is a viral replication with epithelial destruction that will cause this or the punctated epithelial keratitis. What is the difference between the punctated epithelial keratitis or the pseudodendrites and dendrites? We said that in the herpes simplex there are dendritic lesions. The dendritic lesions of the herpes simplex, let me show you again. The dendritic lesions, they are having terminal knobs. These terminal knobs are characteristic for true dendrites. Terminal knobs. But for the herpes zoster, there are no terminal knobs or no terminal bulbs. There are just a blunt end or tapering end. These tapering end are for the herpes zoster ophthalmicus, not for the herpes simplex. There is no ulceration. There is minimal staining or self-limited condition. So actually, Here is there is no actual invasion of the epithelium. So actually this is a self-limited condition. The treatment here, those patients don't receive topical antiviral, no need for that. It will be just treated by artificial tears or even steroids. Those patients, these pseudodendrites appears for a few days and resolve in 4 to 6 days. Okay, so this is for the epithelial keratitis. For stromal keratitis, they occur some 50% with epithelial disease, usually start within the first 2 or 3 weeks with namular subepithelial infiltrates. Namular infiltrates like disc-shaped small multifocal lesions with deciform keratitis, like the same way that the epithelial keratitis will present with. Okay, so this is how a patient with herpes zoster will present. So actually don't forget that those patients will having the typical herpes zoster manifestations in which there is skin lesions that are respecting the midline, skin lesions respecting the midline, having dermatomal distributions. So you diagnose those patients from the skin lesions rather than the corneal lesions. You see the skin lesions respecting the dermatomal distribution. You see what's called Hutchinson sign, or involvement of the tip of the nose, which will indicate the involvement of the nasociliary nerve. So you would know that the cornea is involved in many occasions. So this is how would you diagnose or suspect a patient with herpes zoster. So patients with herpes zoster, they do not proceed or not develop true dendrites. It is just a pseudodendrites. Remember the differential diagnosis of a dendritic lesion. It is A, B, C, D, H. What are these? A for acanthamoeba. Remember, we just mentioned it. B for abrasion. If a patient has healing abrasion, they will develop something like pseudodendrites. C for contact lens wear, can also do abrasions, and these abrasions can give the pattern of dendritic lesion. Some drugs can give the appearance of dendritic lesion, such as antivirals, beta blockers, latanoprost, and H for herpes zoster. So not every patient with dendritic lesion, you say it is a dendritic ulcer. It can be a pseudodendrite. So what will be the treatment for patients with herpes zoster ophthalmicus? The treatment is systemic. Again, the main treatment for the herpes simplex is topical. We only reserve the systemic for non-responsive cases. But here in the herpes zoster, no use for the topical treatment. It is only systemic treatment. This systemic antiviral therapy should be initiated 72 hours of the onset of the vesicles, and this should be continued for 7 to 10 days. Again, it should be 72 hours of the onset of the vesicles, like the patient is developing the rash, and within 72 hours, this will be like the golden period for initiation of the antiviral treatment. After that, the patient may have more incidence of developing post-herpetic neuralgia. So those patients received acyclovir 800 milligram 5 times per day. This is double the dose of the viral infection by the herpes simplex. So for herpes simplex, they receive 400 milligram 5 times per day. But for herpes zoster, it is 800 milligram 5 times per day for around 10 weeks to 2 weeks. Or valacyclovir or Valtrex, it will be 1 gram 3 times per day, or famciclovir 500 milligram 3 times per day. As I told you, no benefit of topical antiviral, and there is topical lubricants and preservative-free will be helpful to relieve these pseudodendrites. So this patient of herpes zoster ophthalmicus, although he has severe pain over his dermatomal distributions, like if the herpes vesicles are present in his face, in his mid-side or mid-face, so he will have severe pain, but he doesn't have this severe pain of the eye. Remember that very well. The eye, he will just complain of maybe mild discomfort and maybe nothing at all. So those patients, remember that, those patients are usually referred to you from the dermatologist, because the dermatologist knows that the herpes zoster will cause some affection to the eye. But usually they don't present to you as a primary case. Okay. Dr. Al Mukhtar, yeah, ganciclovir eye drops. Yeah, ganciclovir is present as eye drops. I even use them in my practice. Okay, so this is the treatment for patients with herpes zoster ophthalmicus. I hope that this is clear. So in order to understand the spectrum of herpetic eye disease, so we said many things, but still there are other conditions do the herpes can cause in the eye. So what will be the spectrum of herpes simplex and herpes zoster? For herpes simplex and zoster, both of them can have some manifestations in common. Like both of them can cause proliferative conjunctivitis. So for the herpes simplex, especially in the primary disease, herpes zoster, it can involve the dermatomes supplying the eyelids in the reactivation. Epithelial keratitis in the herpes simplex can cause dendritic ulcer and geographical ulcer. For the herpes zoster, it will cause a pseudodendritic ulcer. Both of them will cause stromal keratitis in non-necrotizing and necrotizing fashion. So both of them can cause non-necrotizing deciform keratitis. And the herpes zoster also will cause non-necrotizing deciform keratitis and also nammular keratopathy. And then the necrotizing can also be present in the form of interstitial keratitis. Both of them can cause neurotrophic keratopathy because it is actually a virus that involves the nerves. So it can cause denervation of the cornea, can cause lipid keratopathy. So both of them also can present with that. But the herpes zoster can also have other manifestations like mucus plaques, like episcleritis and scleritis, anterior uveitis, acute retinal necrosis, optic neuritis, and ocular cranial nerve palsy. So basically, the herpes zoster can cause inflammation of any tissue in the eye, not only in the cornea. Dr. Atif, herpes zoster has tapered end or bulbs? No, has tapered ends. The bulbs are present in the herpes simplex. Okay, this is the spectrum. Let's now discuss some landmark studies about the herpetic viral infection. The herpetic viral infection, there are two landmark studies that are called herpetic eye disease study 1 and herpetic eye disease study 2. So let's see what are the results of these studies. The herpetic eye disease study 1, this study was done to check the difference or the effect of different medications on stromal keratitis and herpes simplex uveitis. So they tested the patients with herpes stromal keratitis and uveitis to see whether the steroids, topical steroids, and oral antiviral and systemic antiviral have a kinds of effective or no effect. So the topical steroids are effective, according to the result of this study, the topical steroids are effective in stromal keratitis in patients on topical antiviral. So that's why we are giving topical steroids for patients with deciform keratitis under cover of topical antiviral. According to this study, it showed that oral acyclovir has no benefit in patients with stromal keratitis with topical steroids and antiviral. So systemic antiviral for only stromal keratitis is, according to the study, has no benefit. But we give it because it is usually associated with uveitis, as oral acyclovir is given for, it is shown to be effective in patients with herpes simplex uveitis with topical steroids and antiviral. So this is the result of herpetic eye disease study 1. Again, topical steroids effective in stromal keratitis. Oral acyclovir showed no benefit in patients with stromal keratitis. Oral acyclovir showed to be effective in patients with herpes simplex uveitis. Another study is emerged or was emerged many years ago after the herpetic disease eye disease study 1 is called the herpetic eye disease study 2. The herpetic eye disease study 2 was done to investigate the use of prophylactic dose of oral acyclovir. Like, who are the patients who should benefit from a prophylactic dose of the antiviral acyclovir? So this study concluded that oral acyclovir 400 milligram 2 times only per day, this is the prophylactic dose, for 1 year after resolution of ocular herpes simplex virus reduced the risk of recurrence of herpes simplex virus around 45 or 50% in 3 kinds of patients. Those who develop 2 attacks per year, more than 2 attacks of herpes simplex per year, or those patients with history of herpes simplex virus and undergoing corneal graft for 1 year. So those patients who are doing corneal graft, they should be on maintenance dose of herpes simplex virus or of oral acyclovir 2 times per day, because actually they receive long-term steroids, and this steroids can cause reactivation of the herpes simplex. Also, patients with eczema herpeticum or atopic dermatitis and herpes simplex, they also will benefit from prophylactic dose of oral acyclovir 2 times per day. Okay, so these are the results of herpetic eye disease study 1 and herpetic eye disease study 2. I hope that this is clear. Actually, this is okay, we already said that. It's just an extra slide. Okay, so these are the infectious keratitis that will involve the epithelium and stroma and endothelium. And finally, we have a final kind of infectious keratitis, which has a specific feature that it tend to have a primary stromal involvement. This kind of infection is called interstitial keratitis. Interstitial keratitis. So what is the interstitial keratitis? It is inflammation of the corneal stroma without primary involvement of the epithelium or endothelium. So the organism or the kind of infection or kind of inflammation doesn't always have to be an infection. Start mainly by the stroma. So the epithelium is normal and the endothelium is normal. So what are the kinds of etiologies that will cause interstitial keratitis? The first and foremost important is the syphilis. Like, syphilis is accounting for around 40% of interstitial keratitis. And what kind of syphilis? For MCQs, what kind of syphilis? It is mainly the congenital, but also acquired syphilis can cause interstitial keratitis. So if it asks you in the MCQs, does both acquired and congenital syphilis will cause interstitial keratitis? The answer is true, is correct. Okay, so what are other etiologies? So bacterial, as we mentioned, it is the syphilis, Lyme disease, tuberculosis, leprosy, brucellosis. For the viral, it can be herpes simplex virus. We said it can cause interstitial or stromal keratitis. Herpes zoster as well, Epstein-Barr virus, mumps, measles, parasitic like onchocerciasis, acanthamoeba, and mycosporidiosis. Immunological etiology such as Cogan syndrome, sarcoidosis, and contact lens use also can lead to that. But what is the Cogan syndrome? This is also asked in the MCQ. Cogan syndrome is a patient who has a triad. This triad of interstitial keratitis, stromal infiltration or stromal inflammation without involvement of the epithelium and endothelium, and nephritis. So those patients usually present later on by renal failure. And also they have a problem with hearing. They have sensory neural deafness. Sensory neural deafness. So remember this triad: interstitial keratitis, nephritis, sensory neural deafness. Can you tell me what does this triad remind you of? What is the other triad that we mentioned earlier that also would have renal problem, hearing problem, and another ocular problem? Any clues? What do you think? What is the triad that we mentioned that will cause 3 things: nephritis, deafness, and anterior lenticonus? Exactly, as you all mentioned, it is the Alport syndrome. Excellent. So remember these are hot topics in the MCQs. Also, autoimmune diseases can result in interstitial keratitis, such as rheumatoid arthritis, granulomatosis with polyangiitis. This is the new name for the formerly called the Wegener granulomatosis. It's now called the granulomatosis with polyangiitis. So what will be the presentation? As I told you, those patients have primary stromal inflammation. So they will have inflammation of the stroma. This inflammation will invite vascularization. So there will be a blood vessels invasion. And this blood vessel will try to bring antibiotics. It try to relieve the inflammation. As the inflammation is resolving, this will result in scarring. This scarring will be eventually happen, but after that, these blood vessels will ooze lipids, leading called lipid keratopathy, vision together with the scarring, and eventually there will be some sort of what's called ghost blood vessels. Ghost blood vessels are empty blood vessels present in the stroma, so they will be empty in after relief of the acute attack, but if there is, sometimes they can refill, causing intracorneal hemorrhage, leading to hemorrhage within the cornea. But for many occasions, mostly they are becoming quiescent all over the entire life, and you just, when you see them, you consider that those patients underwent interstitial keratitis. So this will be a sign for diagnosis of a previous attack of interstitial keratitis. So this is how would a patient with interstitial keratitis present? How will we manage? Investigations. The first important investigations, if you have a full list of investigations and they asks you which investigation would you choose, it will be the first and the foremost will be the syphilis serology. We have different kinds of syphilis serology, like rapid plasma reagent, venereal disease research laboratory, fluorescent treponemal antibody, microheme agglutination treponemal antigen. So these are the different investigations used for diagnosis of syphilis. If the syphilis is negative, then you can test for other causes that we just mentioned. Treatment according to the etiology. If it is syphilis, they should receive systemic therapy like penicillins. They should receive steroids and steroids to control the inflammation. Steroids will minimize the stromal inflammation. Cycloplegics will relieve the pain. If the patient is lived with residual stromal opacity that is visually significant, then the treatment will be keratoplasty. Okay. So this for the interstitial keratitis.